So again, I'm a spine surgeon at the Rothman Institute. I practice primarily at Capitol Health and Center City in Philadelphia. And a lot of my practice is again trauma, degenerative spine, cervical and lumbar spine, and some deformity corrections. I do apply minimally invasive um, techniques to my practice, but only when it is applicable. A lot of patients do come to the practice asking for minimally invasive approaches to surgeries that or conditions that are not amenable for that. So also, being grounded on what's possible is very important to me. Today, I was asked to talk about back pain, and back pain is a very broad topic, as Matt will also discuss. There's many reasons why people have back pain, and we have to learn to differentiate between back pain and leg pain. In this setting, we're going to focus on back pain, and the title of the presentation is low back clutter. Why low back pain gets doctors to stutter is because there's many conditions. And when a patient says, well, why do I have back pain? There's many reasons why a person should have back pain. So there's a lot of work we need to do to try to figure out where it's coming from and what we can do to help. In this sense, there's back pain is a very prevalent condition. The lifetime prevalence, which means that about 70 to 85% of you guys will experience back pain at some point in your life. Every year, about 15 to 45% of people experience back pain, and that leads to disability, increased cost, not only because of time lost at work, but also, cost of healthcare to treat the back pain, and also cost to patients to get that back pain treated. Is the second most common reason to visit a physician, and it affects about 2% of the workforce every year. So as you can see, it's a significant proportion of the morbidity in our healthcare system. When we think about back pain, when you experience back pain, we're gonna think about it in two ways: acute low back pain, and in that sense, the majority of the time is a muscular condition, like a paraspinal muscle strain. And in the majority of cases, we can treat it with what we call benign neglect. We know you have it. We can prescribe some anti-inflammatories. You can do some physical therapy, but majority of the time, it's a self-limited disease. Within 1 to 3, 4 weeks, you have significant improvement. And by 2 weeks, 80% of people say my back pain is gone. By 3 months, over 90% of people say their back pain is gone. So in this case, in general, it's a muscular condition, and it happens with activity, and it goes away with time. In observation, anti-inflammatories is generally the way we treat it. The other form of back pain that we have is chronic back pain. When that back pain doesn't go away after 6, 12 weeks, and it reaches a point where it's 3 to 6 months. Well, we call that chronic back pain. It's been bothering you for about 6 months, and it doesn't respond to conservative management approaches. You've done physical therapy, you tried anti-inflammatories, maybe even some injections, and it's still there, and it affects your quality of life. About 85% of people, it's difficult to elucidate a source of pain or what's creating their back pain. So when you work with your providers, you got to really pay attention and really try to focus on very different modalities to try to focus on what are the sources of your pain and try to find a solution. And then again, there's other type of population of patients that may have conditions because of psychosocial problems or secondary issues. Workman's compensation sometimes can be a problem because the employee has one view of how they want to get better, but most of your employer sometimes has a different idea in how they want you to come back to work. So that can be a problem as well. So what causes back pain? Again, today we're going to focus primarily on isolated back pain, not lower extremity symptoms. So if any of you have sciatica or radiculopathy, we're not going to talk about that. We're going to talk about primarily axial back pain at the belt line. Sometimes herniated discs can cause radiculopathy or sciatica. Sometimes they can cause back pain only. And so we're going to focus only on the back pain portion. And the way to think about back pain is the Kirkcaldy-Wallace tripod theory. Your back pain, your vertebral bodies, your spinal column, the bones in your spine have 3 points of contact: the disc that sometimes herniates, and the facet joints, which are the joints in the back right here. If you can see my arrow, that organize your motion. And if any of those 3 points in the tripod get damaged or get degenerated, then you're gonna develop one form or other of back pain. The key portion here is the aging disc. That's the biggest problem. Is as we get older, the intervertebral disc ages. We lose cells in the disc. We lose water content and the cushioning components of the disc, the proteoglycans. The type of collagen that keeps the disc in place, the annulus fibrosus, the surrounding disc, or the jelly in the middle, you lose some of that collagen component. And so then you decrease the height of the disc, you dehydrate the disc. You can have a tear, which is what we call an annular fissure, or you become mechanically incompetent, it starts collapsing, or you have arthritis and the bony changes. And so when that happens, we end up having a problem with the degeneration of the disc. As we degenerate the disc, you lose the height of the disc, you develop arthritis at the disc level, and that increases the motion at the facet joints, which are the little joints in the back. And then they start decoupling, meaning that they don't align perfectly, and then you develop arthritic joints in the back of the spine as well. And that's the vicious cycle. As one gets worse, then the other one gets worse, and as the other one gets worse, that affects the front of the spine. And so, it's a self-fulfilling cycle that gets worse over time. And so what ends up happening in the end is you can see this picture when you have significant disease. Well, you can see in the top and the bottom, you have some form of disc. In the middle, your disc has pretty much autofused and there's no motion. And your body does that to try to prevent the arthritic disease developing from continuing to move and causing pain. But at the end of the day, that's one of the sources of significant pain. And a lot of patients say, well, why don't you just fuse my spine? Well, that's a very good question. A lot of people say, well, if I'm already autofused, why not doing surgery and fusing my spine help? And we'll address it a little bit later. It doesn't always translate to an increased quality of life when you perform surgery in this type of patients. So again, spine surgery is not as easy. We like to make fun of our arthroplasty colleagues saying, oh, like hip replacement is very simple compared to what we do in the spine. Both subspecialists have the difficulty, but at the end of the day, when we talk about the spine, there's a lot more difficulty in trying to address the sources of pain. Not only one hip, it can be many areas in the spine. This has been addressed a lot of the times in Europe. There's 3 very important studies that were done in Sweden, Norway, and the United Kingdom to try to differentiate between surgery or no surgery for back pain. We're going to go one by one so you guys understand. The one from Sweden, there was so in all 3 of them, they looked at patients between 25 and 60 years old that had back pain for over a year. Had more back pain than leg pain. Again, we're focusing on back pain, and they were under their government plan for health insurance. It's less than 2-level disease. We're going to keep it simple, and they had imaging, and they were trying to see how they did over time, whether they treated them with surgery or no surgery. The one from Sweden in 2001 had about 300 patients. 72 were treated without surgery, and about over 200 with surgery. And it was some form of fusion, and after a year, they saw that the people that had surgery had improvement in their back pain, and they felt better. Not necessarily very significant, but you can see in the lines, the one with the surgery was slightly lower than the other one. So that's a good sign. A lot of people said, "Oh, great, then back pain may be treated with surgery." But at the end of the day, when you talk about statistically significant scores, only half of the measures that they looked at really revealed that there was an improvement. Yes, there was a reduction in all measures of disability, but whether or not that made a difference, it's something that we needed to look into more. The surgical group and the non-surgical group, both of them said that they felt better, but the surgical group tended to say that they felt much better many more times than the other guys. A lot of criticisms for that study was that, well, the surgeries were all standardized. The same type of surgery was done for the patients, whereas the physical therapy people or the patients that underwent non-operative management was not standardized. They kind of left that on their own. It was not the same plan. So then you can't really compare both groups if you didn't treat both groups equally within their cohort. And so other studies were done to try to address this situation. Then the one that they did in Norway is about 64 patients, 27 had no surgery and 37 had surgery. And again, the ones with surgery ended up getting a fusion. And in this case, they had a standardized structured physical therapy program that was 24 hours a week. And in this case, you can see here, there was no significant difference. People without surgery and with surgery did about the same, And, that's also encouraging because then, okay, well, the previous study had some faults. We addressed those faults. And then this is what we see now. And again, in this case, equal improvement in back pain. There's statistically less leg pain, but remember, we're not talking about that when you get surgery, but not necessarily the back pain. And so that is important to consider. And then the last one done in the UK, about 350 patients, half and half surgery and no surgery. And then they were standardized programs in physical therapy and the same type of surgery. And so the one limitation in this study is that there was a lot of crossover. People from one group switched to the other and got surgery when they weren't supposed to, and people that were going to get surgery decided against it and went back. And so that kind of clouds the results a little bit. But overall, in this case, we see that surgery and rehab was about the same. There was no significant difference in whether or not you recovered from your back pain, whether you had surgery or not. So, well, does spine surgery improve back pain? As we saw, two of the studies said not necessarily. One of the studies with some flaws said yes, it does. And so that's something that you have to discuss with your provider before you decide to undergo surgery, because, like I said before, spine surgery is not something that we take lightly. Where does the back pain come from? Again, there's multiple sources. It's not just only one joint. There's multiple joints, multiple levels. And so in this case, we can see here that of people that have back pain, 82% of those have a spinal pathology. All right. Now, out of those, 65% have only a spine pathology, but you can see here on the left side that 15% of those people not only have a spine pathology, also have an SI joint, which is right here in the pelvis and the sacrum. 25% have an SI joint or a hip problem, 12% have a spine and a hip problem, and 10% have another source that we can't discover where it's coming from. And so it's a very complex picture. It not only comes from one source, there's multiple places where it can come from. Now, this is a very interesting study, and the reason I put it here is because I wanted you guys to realize that there's a big study done, even when people are not complaining of back pain, they did a study in asymptomatic people, and they did imaging and other forms of examinations, and they saw that people between 20 and 39 years old in imaging, about 50% of people have bulging discs, but they don't necessarily have any symptoms. When you reach your 40s to 59, about 50% of people have bulging discs, and almost 60% of people have degenerative disc disease, but they don't have any pain or any other symptoms. And once you reach to 60 to 80 years old, you can see here almost 80% and really 93% of people have either a bulging disc or degenerative disc disease. So, but they have no symptoms. So as we age, these changes happen to the majority of us, whether we have symptoms or not. And not everybody develops symptoms. So then I caution you to get an MRI or get imaging, see disease, and then seek treatment if you don't have symptoms, just because you think that it may prevent you from having pain later. You won't necessarily develop symptoms. So don't let somebody do surgery on you based on an MRI and not on your symptoms and on your clinical picture. Now, this is another very important study. Again, that same MRI, that's an MRI in asymptomatic individuals. They did it in 46 people, 20 to 50 years old. At 1 year, people that had disease showed that 41% of those progressed in the disease, and the imaging got worse, but they don't necessarily develop symptoms, right? Only 5% of those people ended up seeking treatment for back pain. And about a little bit less than half had episodes of back pain that didn't need treatment and were self-limited. So again, imaging does not mean that you need a surgery or you need any treatment. You gotta work with a provider that really treats you as a person, and with your symptoms and your clinical condition, and they don't only look at the imaging. Now the next page here. So now this is going back to whether if you get surgery, well, is your back pain going to get better? This is a study done here in the US. Lumbar spine fusion for chronic back pain. If you have degenerative disc disease, like I showed you, I'm going to go back because I want to make a point of this. 90% of people, over 90% of people between 60 and 80 years old are going to have degenerative disc disease, dark disc disease. That doesn't necessarily mean they're going to need surgery or that they have any symptoms. But that's why there's this trial that said, well, if you have degenerative disc disease and you have chronic low back pain, is a spine fusion going to help you? And then they ended up in 3,000 patients, and they did a fusion, and they did have some improvement in their back pain. 3 points in pain went down. 71% of people were satisfied with their condition after surgery, and compared to 55% in the people that didn't have surgery. And so that was a very encouraging result. Now, is this something we advise for everybody? Not necessarily. It's a viable option for people that have failed all other forms of non-operative management, and it's a form of improving condition. But if you remember from the previous study, even though they're satisfied with their condition, it doesn't mean that their pain improved significantly. It was only a 3-point decrease in pain. And so you have to be hesitant to undergo risky surgery if your condition is not going to significantly improve. And so now the next point is, what are the causes of back pain? And this is for all of you that missed some of the one before, this is really the important part. I think this is the one that the portion that most of you are going to be interested in. And is, what are the causes of back pain? I'm going to divide it into two: structural disorders and non-structural disorders. I'm going to focus on the one on the left. On the right side, you have neuropathic pain. That would be maybe diabetics or people that have not engaged in exercise for a while. If you have hip disease or medical illness, that can also cause back pain. but we're going to focus on the ones that have a spinal pathology and things that can be addressed by non-operative or operative spine providers, someone like Matt or myself. And so in this case, the first source of pain is facet pain. Remember those little joints in the back end of your spine right here. They come from the lower vertebra and the upper vertebra, and they have cartilage in between. Well, with time, those joints in the cartilage tend to degenerate and become inflamed. And about 15 to 30% of people with chronic back pain have facetogenic disorders. It is degenerative nature. It's an arthritic condition. Just like people get arthritis in their knees, they can also get arthritis in their back. And this is what we can't stop. Degeneration just happens to everybody over time. And at some point, it becomes painful. How do you diagnose it? Well, you got to get a history, an examination, and imaging. And based on that, if your back pain is primarily at the belt line and not shooting to your legs, and it hurts you when you move and you twist your spine, well, that can give your providers an idea of where it's coming from. When you have facet joint pain, these are the areas where the pain tends to distribute. It doesn't necessarily go down to your legs. It tends to stick around your flanks and the paraspinal, the areas around the midline of your spine, not necessarily at the midline. It's not in the midline only. It's to the left or the right of the midline. And this is what we call facet joint pain. How do we diagnose it? After getting the imaging and after getting the examination, we have you see physical medicine rehabilitation providers that do something called a medial branch block. They put an anesthetic with an injection at the joint, around the joint to block it. And if that decreases your pain, then we know that the source of your pain is coming from the facet. We do it twice, and if that works, then we do something that's called an ablation. Now, a little corollary here, sometimes providers try to do an intra-articular facet injection. That is not as reliable as doing the medial branch block, which is around the joint, not inside the joint. And if the medial branch block helps, well, then we send you to get an ablation. It's a neurotomy where they burn the nerves that innervate or that provide a source of the nerve sources of that facet joint. They burn them, and that tends to kill those nerves, and the pain goes away for a significant period of time. Most of the time, about 9 months to a year. And it tends to recur because your body's very good at regenerating those nerves, and then we can repeat it as needed. Now, the key is to know, well, is that something that I can continue to do for a long period of time? And that's something that you and your provider have to discuss. Or if there's other forms that you can treat that pain, including a surgical intervention, which is, like I said before, something that has been seen to help in certain conditions like degenerative disc, but not necessarily in the facet. Now, another source of back pain can be the SI joint. I have a lot of patients that come complaining of SI joint conditions. And again, this is related to the spine, the sacrum, and the iliac bones, the iliac wings, is that joint in between them. It's right here. That's the sacrum. That's your ilium. And this little line, you see the red circle, that's the sacroiliac joint. And about 15% of chronic back pain patients have sacroiliac joint inflammation that leads to pain. How do you develop that? Well, a lot of times it's car accidents or, a very active lifestyle as a young kid or an athlete. They develop arthritis from a lot of movement, just like people develop arthritis in their knees or their hips. Again, an accident can cause that. In pregnancy, the ligaments tend to loosen, the joints tend to loosen up and then cause degenerative processes, and that can lead to pain. Sometimes it just happens with aging, genetics. Or sometimes it can happen if you got spine surgery. By getting a fusion above, you increase the stresses below, and that can degenerate the joint in the lower portion of the spine. So that can also be a source of your pain. Why do we consider this an important condition to understand? Well, that's the sacrum and the ilium is the base of your spine. All the forces get transmitted and dissipate from the spine down to the legs through those joints. So as you can see, if you have a very active lifestyle, a lot of stress can pass through that joint over time and cause significant degeneration. There's also large muscles, the gluteus and the hip muscles that cause movement of the pelvis, and that can also lead to degeneration. What are the prevalence? This slide is mostly to say that there's a lot of different conditions that lead to sacroiliac joint pain, and is very prevalent in their population. So where do you see that? And this is the very key figure is people that have SI joint pain. You can see the numbers here. I want you to focus on the person where we're seeing the backside on the right side. Most of the SI joint pain is concentrated in the gluteus and then in the upper portion of the thighs, not necessarily in those other regions. And if you compare that to facet joint disease, the blue chart has the facet joint pain and the white chart has the SI joint pain. as you can tell, they overlap. So it's very hard to sometimes elucidate if a person has a facet joint problem or a sacroiliac joint problem. And that's where our physical therapy colleagues, as well as your um, physical medicine rehabilitation providers, can help us with injections and blocks and maneuvers, figure out where the pain is coming from. There's also physical examinations maneuvers that we can do in the office. And if we get 3 of those positive, it can show that you have SI joint pain. And I've done this on my patients, either a compression test on the left where we put you on your side and push down to compress the pelvis, or a distraction where you're facing up and we push your iliac anterior and superior iliac spines down, and that's going to widen your pelvis and lead to distraction and pain. You can also do something, a Faber test, where you flex one of your knees and we push on one side and distract in the other. Or you can do a thigh thrust test where you push the sacrum up and the leg down, and that creates a shear force between your SI joint and leads to pain. If this is another one, the sacral thrust, where we push down on the sacrum. Any of those is positive, 3 of those, then we can be more confident that a diagnosis of sacroiliac joint inflammation is part of the problem. And what's the standard? Well, the best way is an SI joint injection. You get an injection at the SI joint, and if your pain improves, then we can be more confident that that's the source of your pain. When you have sacroiliitis, there's something we call the New York criteria. If you had more than 3 months of back pain and taking deep breaths leads to pain, you have limited range of motion in your lumbar spine, as you can see down here. If the increase in your lumbar spine range of motion is less than 5 centimeters, well, then we know that you have limited range of motion, and that can be a source of sacroiliac joint inflammation. It's a sign that you have SI joint inflammation. And so we treat it with physical therapy, strengthening your gluteals. Matt may discuss more about that. Continue your mobilization and activity. We can do lidocaine patches, anti-inflammatories, or corticosteroid injections. Something very important to understand is that SI joint fusions, surgery which fuses the joint, is not necessarily a guaranteed success. In my experience and my colleagues at Rothman, about 50% of people that get the fusion get better. The other half doesn't necessarily get better, and it stays about the same. So undergoing a risky surgery for something that has a 50-50 shot is not always advised, although in some patients, when it's a clear diagnosis, it does help significantly. Another one is spinal stenosis, and many of you may have heard this. When you have compression in the spine, narrowing of the canal, you have pain in your legs. Again, we're going to focus on spinal stenosis in the setting of only axial back pain, pain at the belt line. And then you can have the classic symptoms, right? If you have stenosis, people will develop weakening of the legs, pain in the legs, difficulty walking, but that is treated with surgery for the symptoms in the legs, not necessarily in the back. When you have that back pain, it's not necessarily affecting a specific nerve root, and you're not going to have a normal distribution like a sciatica or radiculopathy. It sometimes is in a disorganized pattern, and it usually affects both legs. And what happens here is when you have degeneration, you have arthritic disease, you can see on the right side of the picture, the size of the canal is very narrow. And that is because there's arthritic disease, there's compression of the spinal canal, and that can lead to irritation of the nerves in the area, and that can cause back pain. Most of the time, patients treat that on their own by splinting. They change their postures, they flex forward, they retrograde their pelvis. They usually say, oh, if I walk in the grocery store holding a shopping cart, I feel great. Well, that's because you're trying to lean forward, but purposely increase the size of your spinal canal and decrease the pain. And so that's one of the ways that we can diagnose this type of condition. This is a chart that a lot of you are going to like. It's when you have spinal stenosis and back pain, what are the things that you do and what causes pain? Let's start. So if you're sitting and you have more pain, that tends to be related to disc disease. Sometimes when you sit, you may or may not have facet disease, but your pains decrease if you have spinal stenosis. Now, when you're standing is the opposite, right? If you're standing, you have less pain at the disc, more pain at the joints, and more pain in the canal if you have stenosis. And then when you flex, you tend to have more pain at the disc when you bend over, more or less pain in the facet, but you have less pain if you have spinal stenosis. And then if you get an epidural steroid injection, usually that doesn't affect the disc or the facet, but you get much better if you have spinal stenosis. And if you have a medial branch block, usually does not affect the disc or the spinal stenosis, but you get better when you have facet disease. So this is a nice chart. And again, the way to treat this is flexion-based body mechanics, physical therapy. Sometimes they help you with postural control, paraspinal muscle core strengthening, and that can help your posture and your the ability to increase the volume of the surface area of the canal of your spine and decrease pain. You can get injections or you can get surgery. But remember, all the studies show that surgery is better for leg pain than back pain. So going through surgery and waking up and realizing you still have the same pain is sometimes very disappointing and sometimes not advisable to go through the risk of surgery when you're not going to get better. Another condition that we may discuss is that we may see in the office is Bastrov's disease, and that is interspinous ligament inflammation. It's very not necessarily significantly common. The prevalence is I have maybe seen once or twice, and it usually happens in athletes. We have hyperextension, usually gymnasts or baseball players, where the spinous process is here. The back bones in the spine tend to collapse to collide with each other, and then there's inflammation in between. You see above there's space, and in this one there's no space, and that the continuous collapse and compression and trauma between those two bones can lead to inflammation and pain. So it's better when you lean backwards because you're compressing that space, and better when you bend forward. There's usually tenderness in the spine. You can see here in an MRI, you can see a little bit fluid in between the two. And usually you can treat it with a steroid injection. You don't usually treat it with surgery. I was going to focus on a couple of others, but these lead more to back pain. Spondylolysis is a pars defect. Some people can have a little fracture in the bones from the front to the back of the spine. You can see it here on the right, on the left side, on the right side, sorry. And that can lead to some back pain, but primarily leg pain. And in that sense, surgery is advised, but it's, out of the scope of the talk, of this talk. And then spondylosis, that's just arthritis, and we covered it before. These are some of those nerves that can cause back pain when you have spondylosis or arthritis. These little black lines, these are the nerves. And so from the nerves that come from the spine shoot out, and you have the sinovertebral nerves going into the disc, and then the nerves going into the facet joints. And those are the nerves that tend to cause the pain that can be treated with a medial branch block or with an epidural steroid injection. And so what causes back pain? That's very difficult to tell you. It's very complex. When it doesn't go to the legs, it's really difficult to pinpoint a solution. And so you need to go to a provider that gives you the time and the resources to try to elucidate the pain and find you a treatment option. It can either be with physical therapy, anti-inflammatories, or physical medicine rehabilitation injections, but very few times is surgery the answer. And that's about it. Sorry it took so long. I want to thank one of my fellows, Brian Kramer, who helped me with the talk. And happy to answer any questions.
Do you know if acupuncture can help?
Sorry, say that again?
Acupuncture can help? I don't know.
Acupuncture?
Yes, acupuncture. So it's interesting that you say that. Yes, we have seen some studies that show that acupuncture can be an adjunct to physical therapy or anti-inflammatories. So yeah, I think you have a provider that is reliable. It's definitely something you can try. And I actually send my patients, if physical therapy is helping, but they still have some discomfort, acupuncture is something that you can definitely try.
Thank you.
I wanted to say for anybody that wanted to get an appointment, I see a lot of text messages here. I'm gonna let me tell you the number for my clinic. It is 609-920-9220. And if you call anytime between 9 and 3 p.m., sometimes 5 p.m., but then at the end of the day, they start responding to all the messages. You can leave us you can call and leave a message, leave your name, number, date of birth, and we can have one of our staff call you back to make you an appointment.
There was a question in the chat box. Will you be talking about a spinal cord stimulator implant?
So it's interesting then you say that. So spinal cord stimulators are generally implanted by either neurosurgeons, I'm an orthopedic spine surgeon, or pain management physicians. The studies, I'm big on research, and the studies are 50-50 on that. I do send my patients to get a spinal cord stimulator, but that, in my opinion, that's a last resort. I try to find alternatives before we go that route. But yeah, it's one of the options. In general, it tends to be the last resort.
All right, thank you. I know you're pressed for time, Dr. Canseco, so.
No worries. So again, everybody, thank you. Matt, thank you for having me. Capital Health, thank you for having me. Marsha, I'm happy to see anybody if you guys are interested. Again, my number, I just said it, and you can reach out to my team or Kristen, one of the Rothman team members, is still on this call. She can probably provide my contact information. We also have a VIP scheduling hotline, and if Kristen, can you share that with them? That'd be great.
One other quick question. Somebody just asked, do you ever recommend a chiropractor?
Yeah, I mean, I would do so. You know, there's different, just like there's good and bad spine surgeons, there's good and bad chiropractors. I would want to, we know very good ones, and I would tend to recommend the ones that get imaging before they do any manipulation or procedures, because you want to know what you have before you do a manipulation. Actually, one of our partners, Dr. Hillebrand, has had a very, you guys all want to see this. The New York Times published a very interesting article on chiropractors, and I think it was last week or 2 weeks ago, and they talk about that and whether or not to see a chiropractor and when to see a chiropractor, because just like there's good and bad spine surgeons, there's also good and bad chiropractors. So yeah, it's definitely an option as long as you have a reliable provider.
Okay, thank you. Then
Good
we'll
evening,
move on.
everyone. Thank you so much.
Have a good night. Okay, Matt.
Okay, so Dr. Canseco certainly covered a lot of information about surgery and diagnosis, and you know, I'm going to go into a little more about how we handle back pain conservatively, all types of back pain. So anyway, my name is Matthew Toth. As stated before, I went to Mercer County Community College. I've born and raised in Trenton and Ewing, and been practicing in the field for a while. I went to Rutgers for exercise science, my doctorate in physical therapy in 2010, and I'm board certified in orthopedics through the physical therapy certified agency. So I've been doing physical therapy for a while, and the field is changing, and I hope that in a good way as we get a little more evidence-based. So this is kind of how you feel, you know, when, you know, people talk to you about back pain, you feel like, oh, I can't do anything anymore because I'm just going to hurt my back worse and all those things. But really, at the end of the day, research is dispelling a lot of myths about back pain. And some of these myths are things like I threw my back out. It's colloquialism, basically, when you know you feel like you're having some acute pain in your back and it's sore. This is based on the false assumption that there's a malalignment in the spine. There's literally no research that is going to support this. That's even, you know, there might be a case study or two, but we can't use one case study to extrapolate research, to extrapolate results to a patient. So, you know, basically your back's not misaligned. You just have spasm and pain, and, you know, we're trying to, you know, dispel some of these myths. My posture is terrible. This is an interesting one because it's hard for people to wrap their heads around. Even me, I mean, I was trained about, you know, improving posture, and at the end of the day, posture and pain are not as connected as we previously thought. You know, they've done studies where they study people, there are more incident studies where they study people, you know, that have poor posture, poor sitting posture versus, you know, like your typical upright at attention kind of military posture. And in some of these studies, and a lot of them, the people that try to maintain this upright posture all the time actually end up having more pain. So it's not that posture is so bad, and especially when, you know, we talk about posture as far as correcting someone's posture that doesn't have pain. I mean, there's really not any reason to do that unless you see them doing this for hours and hours and hours. But even then, unless they're having discomfort, it's not something they really have to focus on. The spine is actually a lot more resilient than you might think. and the research is bearing that out. You know, all these other things, I can never bend forward again. Sitting is the new smoking, kind of goes with the posture. These things are not bearing out in the research. And what I want to focus on tonight is something that the medical profession has been using for a long time, that in the last 10 years or so, maybe even longer at this point, maybe 10, 15 years, the physical therapy profession has started to adopt, and that's called clinical practice guidelines. So clinical practice guidelines, basically, you know, they take the best evidence we have and they're going to give recommendations through the best evidence we have. That does not mean that, you know, chiropractic doesn't work or traction doesn't work, or, you know, obviously if someone gets relief through any of these means, acupuncture, it's completely fine, you know, to pursue those things. But the bottom line is that, you know, we want to use the best quality evidence out there to dictate care. And I think in our profession, we've done in the past a bad job at, you know, having consistent care, having a standard of care that we start with, and then kind of going on to these other treatment methods such as acupuncture. Chiropractic is an interesting one. I mean, I don't slam chiropractors. I mean, I know there's people in my profession that might, but they, you know, we're both trained in manipulation, which is the crack in the back kind of thing. And there's good ones and bad ones, and some of the, you know, it's beyond the scope of this presentation to go into that. But basically, you want to start with the best evidence. So what they do in these clinical practice guidelines is they get a bunch of studies and they use these grades of recommendation. I'm not going to go into this, you know, real in depth because it's kind of boring, but the bottom line is, you know, they're based on how good the studies are. Do the studies have blinding? Do they have controls that they compare the treatments to? All this matters because there's a lot of care that is promoted through weak evidence, and the public should be more aware of, you know, someone that's performing a technique that really has very little evidence, because you want to start with the stuff we know works. So they use these evidence. I'll give you a good example from the medical literature. Basically, in this clinical practice guideline, you know, this is for colds, and I'm sure a lot of us have seen, you know, have gone to a doctor with a cough and cold. And obviously this is beyond my scope, but it's a good example that, and a perfect thing, you know, is to look at the highlighted regions that, you know, the grade A evidence stuff is using Sudafed and you know, anti-inflammatories, and you'll see that prescribed a lot. Newer generation non-sedating antihistamines, what these are, like Claritin, Allegra, things like that. They don't have a great benefit. And the last one is the reason your doctor won't give you an antibiotic every time you go in with a cough and a cold symptoms, because basically, you know, the evidence does not support that being done in the first week, which is why they're going to wait a week and if you still have symptoms. But this is based on evidence. It's not just what, you know, their clinical experience, even though clinical experience does have to factor in. So Dr. Canseco talked about this a lot. There's a lot of difficulties treating lower back pain, especially most people want a firm diagnosis. They want to know exactly, you know, what's going on with their back. And many times we can't tell you that. You know, like Dr. Canseco showed you many studies showing that there's these abnormalities in the back. And the problem with using advanced imaging techniques like MRI is that once you see that bulging disc, if you have a practitioner that blames that bulging disc on your pain and doesn't do their due diligence to compare that with your clinical presentation, you know, what happens with that is that you believe that, and that can really the cognitive piece there really can pepper how you act and behave and choose and what you do with your back. And so these, what we call pathoanatomics, they're much less important with lower back pain than we previously thought. Subgrouping. So what they do is, here's what's going on now, is especially with back pain, but in all the aspects of physical therapy, we're trying to do this. Instead of looking at the anatomy, we're going to take different things that we glean from your excuse me, examination, and we're going to take signs and symptoms that you're presenting with. Symptoms are something that you're subjectively telling us, and signs are something that we see. And we're going to classify you based on the best available evidence. Now, that doesn't mean that you fit into one group or the other. We use your signs and symptoms as a guide and try to decide what you would benefit from in these, and we'll talk about what types of back pain benefits from classification, or what they benefit from in different classified groups. But the bottom line is, sometimes you start in one group and you end up in the other. And I think let's talk about the groups. So in the last, there was a clinical practice guideline created by the Academy of Orthopedic Physical Therapy in 2012. You can go on their website. All of these are free. I believe it's orthopt.org. I'll try to put a couple URL links in the chat, but I think you're going to get a copy of these slides. So I did put them at the end, so you have some resources. But acute back pain is anyone with pain less than or equal to 6 weeks. All other back pain was classified as chronic. So these are the first two groups they used. These were classified this way because they have lots of data to show that this is, these are the groups that these two timelines fit in. We used to use a term called subacute back pain. And if you understand that term, it's where you fit between acute and chronic. But there's really no good definition there's no accepted standard there. So they kind of got rid of it just to simplify it for the public and the practitioners. And it's not going to make an effect on anything. So the studies they included had patients that had low back pain with leg pain. These were patients with low back pain, buttock pain, or symptoms extending below the leg. Low back pain in older adults. These were low back pain who are age 60 or older, in patients who are age 60 or older. And post-operative pain. This is, as Dr. Canseco reported, surgery is not always effective. And so that's why they really try to make sure that they're doing all the conservative care first, because sometimes in the past, some less scrupulous surgeons would just do surgery on you, and then you never know if it's going to work or not, because it just, it was a 50-50 shot whether you were going to get better or not. But we know better now, and that's why, it can be frustrating for some people, but they are going to try physical therapy first. They're not going to go straight to injections. There's, a lot of things you want to try first before you get invasive, and you'll actually have more success that way. For acute low back pain, the things that you would benefit from in general are these, and I'll explain these a little bit, but active education and advice to pursue an active lifestyle. And this is one that I can't emphasize enough, that, it's okay for a few days of rest. And, when you're having an acute episode of back pain, obviously, probably everyone's is here tonight because they've had some back pain in the past, and it can be debilitating, and it's okay to rest a little bit. But the evidence is showing that for acute back pain, the the contrary is true, and you should try to stay active. Even if you just go about your normal day and just gradually get back to what you're doing, you will get better faster most of the time. You know, learning about the natural history of acute back pain, like we just said, is another method, and self-management techniques, which I'll give you some resources for later. Thrust and non-thrust joint mobilization. That's if you ever had someone do a joint mobilization where they're kind of like almost doing like a CPR type motion on your spine. That's a non-thrust joint mobilization. Thrust is colloquially what a chiropractor does. And we as physical therapists can also perform those techniques. On certain patients, you know, there's different categories for that, and I'll talk about that a little bit later. But there are patients who fit criteria for thrust versus non-thrust joint mobilization. So that's why we say that, you know, if you have back pain, it's so important that the participant takes a good history, because, or that the clinician does, because the bottom line is that you could be getting a very aggressive joint mobilization and not need it. And that can make things worse. Some people have these stories where they love the chiropractor because they happen to either, you know, they've benefited from it, but others have the opposite stories. Soft tissue mobilization is the same thing as massage, basically. So, and general exercise training is basically what it says. I mean, just staying active, doing, you know, leg workouts in the gym, cardio workouts, you know, as long as they're not pain provoking. That's really where that's going with that. So that's for, if we consider, I should have said, just going back, mobility deficits means like this is localized to your back. There's no leg pain. You can't move in a certain direction, whether it's bending forward or leaning backward. These are where these kind of techniques are very beneficial. For acute low back pain with movement coordination deficits. So this is kind of the patient that is not really able to contract their core musculature well, or like when we do a test on you, if we take gravity out of the picture, you have more motion in the spine, which versus if we take a range of motion measurement and standing. And, you know, so basically, if you look at it, it's almost the exact same thing. And it, you know, it's just a little, we're going to be a little bit more gentle and conservative in these cases, because we might need to start by just showing you how to contract your core, or how to move in a better pattern so that you can get back to the thing you want to do. So the additions here are the specific trunk muscle activation exercises. This would be kind of like your, if you ever been to physical therapy and they tell you to make your stomach tight, like you're going to take a punch, that's called an abdominal brace contraction, and then a draw and maneuvers, pull your belly button towards your spine. These are two ways to get the core contracting. And the way your core should contract before you do a movement, like let's say you lift your arm up, your core should contract first. So we try to promote that pattern a little bit. And, you know, we only do that in the beginning until you kind of get a little less pain and less symptomology. And then we want to get you doing more trunk muscle strengthening endurance. These would be like planks. These would be, you know, some belly presses. We could talk about stuff like this. Side planks. This is the stuff to really get the endurance going. And it is effective in these patients. Leg symptoms. So acute leg symptoms usually benefit from what was known as McKenzie therapy. This is when you go to the physical therapist and they have you do repeated extensions on your stomach. Some people notice movement as a prone cobra, but we just have you do it a bunch of times. If the symptoms come out of your leg, then usually this is something we want to promote, because we want the symptoms out of your leg first. And that might mean that your back pain gets a little worse, but if your leg pain's worse, the general assumption is that your nerve is not as irritated, and we want to start there, because we can do this before you know what you have going on an MRI, because really, like I said before, the back's pretty hardy, and as long as you pay attention to your symptoms, you're probably not going to hurt yourself by at least trying these techniques. And it's not just extension. We can, if you have more of a stenosis, as Dr. Canseco was talking about, we can bring your knees to your chest and do repeated flexion. What I'm talking about is more anatomically based, but the bottom line is some people will have a disc bulge and they'll benefit from bending forward, and you would think the opposite, but they do. And then your general exercise and nerve mobilization. So chronic low back pain. So this is where it gets a little more interesting. A lot of the same techniques apply. However, there's a little difference in if you have a combination of chronic back pain combined with all the what we call affective tendencies, which are like depression, catastrophizing, like, oh, my back's hurting again. It's, now I'm not going to be able to do anything for 3 months. Kind of like this, like mental outlet toward things, is when we start to think about bringing in some cognitive behavioral therapy, which is outside of our scope. But we can certainly, gradually expose you to exercise that you can do, and then ramp that up, and it's proving very effective. So, like I said, the affective tendencies are like depression, symptoms of feeling helpless, patients that don't want to move, they're movement sensitive, things like that. And so with these patients, what we want to do is a combination of kind of understanding how pain works. I'm going to give you resources about this, because we could do a whole talk about chronic pain and pain neuroscience education, understanding that it's hard to not see everything through the pain lens. If you have chronic pain, you're in such discomfort, you're seeing everything through this, ow, my back hurts lens. And it's so hard to address that. And some of that has to do with a poor coping strategy cognitively, and it really does need to be addressed. And what they're finding is that if we classify patients with chronic low back pain for their risk of developing persistent pain using different functional tools, like a little questionnaire you fill out, we can start in a position where the patient will probably have more success. So we're trying to, as you can see, overall, the physical therapy profession is trying to formalize treatment a little bit more, so that you get a more effective, consistent approach, especially from therapist to therapist. It's proving hard to get all therapists on board, but they should be starting there. So we talked about a lot of this already. This is just a table with the defining some of the things I discussed. Trunk mobility exercises, kind of like the McKenzie stuff. Aerobics is anything you can do. Aerobic exercise, especially in chronic pain, is so important. If you can do some kind of repetitive aerobic exercise, it gets blood moving through the system and just is a great adjunct. And multimodal approach is combining any two of these. So we talked about the McKenzie approach with the repeated motions. Treatment-based classification is kind of what I was talking about before. Treatment-based classification takes your symptoms. It says that put you in a subgroup that says you might benefit from manipulation, like what a chiropractor does, or you might benefit from specific exercise, like doing core exercise, like the stabilization, or you might benefit from traction, things like that. So we have different algorithms we use to do that. Lately, there's been some advances in these, and it really does depend on whether there's any red flags. What that is like loss of bowel and bladder. We're going to go into this a little later. All of a sudden you have poor balance. These things are not consistent with something that's just back pain that's unremitting, back pain that's only at night. It's something you definitely need to be seen by a medical provider for, because it could be something else other than mechanical back pain. But most of the time, we can, if we rule those red flags out, initiate treatment. So I know all this research stuff can be boring, but I just want to show you that the field is trying to formalize what works versus what doesn't work, so that we have a good starting point and there's more consistency from clinician to clinician, and that you don't, if I can, get anything forward tonight, it's that just a couple general tips here, and that is rest is fine. Okay, so what should you do? I mean, rest is okay, just not excessive. You want to rest if you need to, but try to move around your house. Do what you can. You're not going to make things worse unless while you're doing it, it feels worse. Really, Dr. Canseco talks about how you have to pay attention to your symptoms because of the difficulties diagnosing back pain. And that's so important. So if you feel like something you're doing is making it worse, you should stop. And I know it sounds simple, but it's the right way to go when you have an acute episode. Obviously, ice and heat, medication that's prescribed by a physician, all these things are okay to start with. Continue your exercises. Don't stop. You're going to the gym or you're doing other things for exercise. Don't stop them just because you're having back pain. Modify them. Do half the rep instead of the full rep. It's just not bearing out in the literature that you should just go lay in the bed. And I usually say, if your pain's lingering more than a week, try to come and see somebody, whether it's Dr. Canseco, or if you do go to a private practice, not in the hospital here, we require a prescription, but private practice, it is direct access in New Jersey. Not many people know that. Most of your insurance companies will pay for physical therapy without going to see a physician. We're trained now a little more in medical screening. So if we think you need imaging, we would refer out. But in many cases, we can initiate treatment without a doctor, and it's legal to do that within 30 days. So after 30 days, if you're not getting better, we have to refer you to another level of care. When should you not wait? These are just as important. If you have constant pain that is not affected by any position or activity that happens suddenly, you got to see a physician. These worse pain that's usually worse at night, you're over 50, you have a history of cancer, and conservative treatments failed. You need to not wait on that and continue to pursue trying to get diagnosed of what's going on. Unexplained weight loss, no relief with bed rest, urine retention, urine incontinence. Saddle anesthesia means like where your inner thighs would contact a horse or your genital area. If you have loss of sensation here, it's a huge red flag. And you should definitely see you should definitely see that. So in general, I have another slide, but you'll get these slides up. I got to close up here. So for some resources, you may be able to click these links. If not, I think you can get these slides. Is that true, Marsha?
Yes, if anyone would like the slides, I put my email address in the chat box. I'll put it in again. As long as you give the okay, I can send them
Yeah.
out. And they will also be in the recording, which will be posted in about a week or two. And I
Okay.
put the link in the chat box for that as well.
Okay. Yeah,
Thank
so I want, this has a lot of resources for perspective with patients. This is straight out of the clinical practice guideline. I highly encourage people to get if you have acute back pain especially, try to read Robin McKenzie's Treat Your Own Back book. He has a Treat Your Own Neck book. He has a Treat Your Own Any Joint book. But the back and neck are what he's really known for. And they're inexpensive, and it may work for you. I've had it work for people, ask my advice outside the clinic without even coming into the clinic. They've gotten themselves better. There's pain neuroscience books you can look at. If you're in chronic pain, I urge you to consider it, as this is the direction that field's going in. Again, I work at Capitol Health System Outpatient Physical Therapy. We have 2 offices. One is right across from Helene Pool, Regional Medical Center. Sorry, I'm from the area. I call it Helene Pool, but I'll never stop. The bottom line is you can get therapy there, or you can get therapy at the hospital here at Hopewell. We have a lot of different specialties. We have pelvic floor specialty. We have vestibular concussion rehab. We treat specialty patients with Parkinson's disease. All of us are most of us are certified in Parkinson's wellness and recovery. There's lymphedema therapists. There's a lot of specialties. So if you're not sure, I urge you to call and ask, because we would love to help you out. So are there any questions? That's pretty much it.